As emergency physicians, we are frequent providers of Indigenous health, and this can be a very rewarding portion of our work. But some find the complex determinants that affect the patient's presentation difficult to manage in the fast-paced ED setting. And this is compounded by the episodic nature of our care and the number of challenges that originate upstream from the ED. But because of the degree of marginalization that Indigenous Canadians face, any improvement in care has the potential to result in very large gains. So today we'll examine how emergency physicians can mitigate healthcare disparity in order to improve health equity in the emergency department. I'm joining you today from the traditional and unceded territories of the Snaymu Nation, and I don't have any conflict of interest to disclose. I don't possess any lived experience from an Indigenous perspective, as I'm an Asian settler. The presentation is made from the perspective of a person without lived experience for other providers, likely without lived experience. The focus is on the deficits of the current healthcare system in order to engage appropriate response from health providers. It does not claim to represent Indigenous perspectives and values on health and healthcare. As part of reconciliation, the onus of learning how to mitigate the harms of the healthcare system and work towards reconciliation and equity rests with settlers. The onus is not on Indigenous peoples to provide this education. This presentation does not seek to replace further training in cultural safety. Rather, it seeks to provide some background to encourage further learning directly from Indigenous voices. And while immensely valuable, we don't have an Indigenous co-presenter today. The primary rationale is that many healthcare providers have yet to critically reflect and draw upon lessons from the tremendous input from Indigenous voices that have already contributed, and we seek to draw from some of these lessons today. Speaking about Indigenous health from the lens of a non-Indigenous healthcare provider is also not an attempt to validate Indigenous voices. These voices are intrinsically valid and don't require further validation by persons without lived experience. Our goals for discussing this topic today is an act of knowledge translation in improving the accessibility of the topic to a medical audience. And finally, the presentation contains material that benefited from the input of Dr. Terry Aldred. Most providers are aware that Indigenous peoples in Canada have poor health status compared to non-Indigenous Canadians. And this gap is made more obvious when comparing Canada with peer countries. Life expectancy in Canada is 81.7 years, and the life expectancy of Indigenous peoples is 75.7 years, which is comparable to that of Hungary and well below the OECD average of 80.5 years. First Nations adults have over double the risk of avoidable mortality, and these indicators show that Indigenous people do not derive the same benefit from the Canadian healthcare system as non-Indigenous peoples in Canada do. And when considering factors leading to these disparities, healthcare providers tend to focus on patient choices or lifestyles or behaviors rather than providers or systemic factors. The roots of the population level health disparities can be traced to adversities across almost all levels of determinants of health. These disparities range from the glaring and obvious proximal determinants to the insidious and systemic distal determinants. While we don't have time to examine the determinants in detail today, the key takeaway is that our societal structures cause harm to Indigenous peoples by preventing fulfillment of basic needs. And these inequities are clearly present currently and not limited to the past. It should therefore not be a surprise that there's a greater need for emergency services amongst Indigenous peoples in Canada. First Nations patients are 75% more likely to visit the ED than other residents. And this can be partially explained by poor access to primary care. Across all age brackets, First Nations patients have lower attachment rates to family physicians in the community. Qualitative research have also elucidated other factors that may contribute to higher ED presentations. Patients may have personal experiences that cause them to choose the ED because it's a place where they feel they're more likely to receive help. This can be related to not feeling welcomed or facing barriers in other community care settings. Accessibility by foot or transit can also be important factors. There's a common sentiment of not wishing to be in the emergency department unless it is a very last resort due to fear of negative experiences. Some people who work in centers surrounding rural areas may have the experience where patients are very reluctant to be transported to larger centers in part because of this fear. It can be tempting to believe that the population level health disparities that we talked about are largely due to the upstream determinants of health. However, it represents only part of the pathway that leads to the population-wide health disparity. We can conceptualize this pathway through this graph here. At birth, adverse birth outcomes already contribute to a disadvantage of Indigenous peoples. And the determinants of health, systemic racism, structural violence, and the impact of trauma exert an allostatic load and likely accelerates the onset of disease and worsens its progression. And when accessing care, Indigenous patients experience health care disparity through impairment of clinical process in processes such as impaired clinical suspicion, assessment, and management, ultimately leading to the population-wide health disparity that we observe. Increasingly, providers are showing concern regarding the performance of the health system for Indigenous patients. However, some clinicians do still perceive little inequity in the care of Indigenous patients. We'll briefly examine 3 forms of healthcare disparity: poorer patient experience, differences in investigation and management, and finally, poor outcome. An example is seen here where Michelle Lebrec visited the emergency department for abdominal pain and received what she thought was a genuine prescription that was folded up and given to her. And she later discovered that this was a crossed out drawn beer bottle on a prescription pad. Her experience is unfortunately not isolated. The In Plain Sight report that was released last November and the data report in December was commissioned by the BC government to assess healthcare disparities that Indigenous peoples face. And as you can see here, Indigenous peoples are 3.2 times more likely to feel not at all safe and half as likely to feel completely safe in emergency departments compared to non-Indigenous patients. Some additional markers of adverse emergency department experience includes longer admitted emergency department length of stay, higher ED readmission rates, and higher rates of left without being seen. The same, in addition to having poor experience, there is some evidence that Indigenous patients receive different care compared to non-Indigenous peoples. Indigenous peoples use specialist services substantially lower, at a lower rate compared to non-Indigenous peoples. And this is not explained by correcting for socioeconomic status or rurality. Comparing geographic areas where there's higher percentage of First Nations populations with those with lower First Nations populations, the former has a lower rate of PCI for acute myocardial infarction by over 25%. And controlling for rurality only slightly reduces this disparity. First Nations patients are half as likely to receive bone mineral density testing even after a fragility fracture. And so it's not surprising that they then receive less frequently a diagnosis of osteoporosis and less frequently receive osteoporosis-related drug treatments. These findings are consistent with a larger body of literature showing race-based healthcare disparities adversely affecting racial minorities. There's also evidence showing that Indigenous patients have higher morbidity and mortality when receiving healthcare, such as surgical procedures. And so there's evidence showing that Indigenous patients do not receive the same care, at least in some ways in process, in some ways in outcome, as non-Indigenous patients. The causes of these disparities are likely to be multifactorial. However, it's unlikely that patients choosing not to pursue care accounts for all of these differences. An example would be that the decision to diagnose someone with osteoporosis is entirely made by clinicians. And that decision then has implication on treatment. And another example with regards to the revascularization with PCI after MI, that is also entirely a physician choice, occurring very quickly within acute MI, and therefore patient's choice and preference likely does not explain all of the differences. Regardless of the specific cause of these disparities, there's an urgent need to address them. It's then reasonable to wonder what factors contribute to healthcare disparity. Healthcare disparity can be attributable to clinicians in three primary ways in terms of impairing the clinical process. First, by impairing the clinical suspicion, and by assessments, and finally by management. So in terms of impaired clinical suspicion, it could be attributable to, for example, lacking the recognition of other biases outside of ourselves as clinicians, and this attribution of presentations due to stereotypes and a lack of adjustment of our pretest probability to meet the context. In terms of how our assessment could be impaired, our history and physical could be impaired, our communication, and as well perhaps with the reluctance to order investigations. And finally, our management could be impaired due to lack of rapport, leading to poor adherence or disproportionate focus on health behaviors, leading to either misdiagnosis or leading to loss of buy-in, neglecting to connect patients with the appropriate resources, or with meeting continuity of care needs. So we'll explore the two, we'll also then, before we dive into each of these, we'll first explore two themes that can affect all three of these processes. The first being implicit bias, and the second being trauma-informed practice, before examining some strategies to improve and optimize each of these care processes. Implicit bias is a phenomenon where an association outside of conscious awareness is present in affecting how we perceive the world. And so this is an association between a group and a stereotype. This may lead to a negative evaluation of a person on the basis of irrelevant characteristics that's not pertaining to your visit, and may not correspond with what you explicitly believe. So for example, a person may explicitly believe that all people are equal, but there may be an implicit tendency to consider certain ethnicities to be more Canadian. There is evidence to show that implicit bias in healthcare professionals is common. Healthcare professionals exhibit about the same level of bias as the general population, and there is a significant association between implicit bias and lower quality of care. Implicit bias is significantly related to aspects of care such as patient-provider interactions, treatment decisions, treatment adherence, and as well as patient health outcomes. Most healthcare providers have a pro-white bias and negative attitudes towards peoples of color. Most studies, I will say, are done in the United States and some out of Australia, and most of the focus is around anti-Black racism, so some degree of extrapolation is required here. Evidence does suggest that the emergency department is an environment that is highly conducive to implicit bias. And triggers of bias include things like fatigue and constrained information overload, and the requirement for quickness to act. And all of these things are very familiar to our ED work environment. And there is therefore an association between ED overcrowding and actually higher post-shift implicit bias levels. As an aside, most of these testing is done by a process called implicit association testing, which is basically testing the reaction time between a provider making association between certain concepts when posed a question. The shorter the duration of the response implies a stronger association, and hence may reveal bias. It is not an entirely controversy-free field of research, but it has been the main instrument for this field. So bias contributes primarily to communication difficulties. Explicit bias affects the content of the conversation, while implicit bias affects nonverbal forms of bias, such as eye contact, mannerism, and speech errors. Bias has been shown to favor mostly white patients. Generally, clinician bias is associated with poor rapport with Black patients. Strangely enough, when those same clinicians with a higher degree of racial bias, when they interact with white patients, they're more likely to be perceived as being respectful of the patient, and the patient feeling like they're well liked. But there's also a lower likelihood of the patient finding the encounter to be participatory. So some evidence-based strategies on how to counteract the effect of implicit bias on our clinical process include seeing each person as a unique individual rather than a representation of a greater population. And this can be done by gathering the social history or involving family members. By connecting with patients' individuality and humanity, some adverse effects of the implicit bias could be mitigated. Another strategy is recognizing how our own response to the patient is as being stereotypic. And so this can include things like our behaviors in terms of limited testing or anticipating poor response or poor adherence, or the use of a non-patient-centered communication style. If we're to recognize the stereotypic reaction from ourselves, we can then encourage ourselves to replace it with a more favorable response that is more focused on health equity and to mitigate the risk factors of poor health determinants. Ultimately, the more durable way to mitigate implicit bias that's been evidence shown is in fact by increasing meaningful interactions. I think subconsciously, clinicians might be treating patients with the aim of restoring the patient's function to their baseline. But this is largely based on our perception of what the patient's baseline is. And so this is entirely limited to our imagination. And unfortunately, our imagination of what the patient's baseline is could be largely informed by bias if we don't have meaningful interactions outside of the clinical context. Information sources like the media or societal stereotypes may contribute to the image of what we think the patient's baseline is. And if we don't challenge these using meaningful friendships or meaningful interactions, we likely have an artificially low baseline if all we see are Indigenous peoples at their most difficult struggling times in the emergency department, and we may risk affecting our standard of care if that's what we imagine people's baseline to be. We'll now shift gears a bit to talk about the second theme, which is trauma. Trauma is a fairly common experience, unfortunately, amongst Indigenous peoples in Canada. And an Indigenous patient may be affected by multiple forms of trauma. Complex trauma is now an increasingly accepted understanding of framing the experience of colonialism and structural violence. And it has now been recognized in the ICD-11 and not yet recognized in the DSM. Many Indigenous peoples are affected, as I said, by complex trauma. And while the main reason for the patient's presentation may not be related to trauma, trauma can still affect the presentation. And the manifestation may be, as you can see on the screen, physical or cognitive, spiritual, interpersonal, or behavioral. And as you take a look at some of those traits have been shown in literature to have produced difficult, both based on literature and likely your own clinical experience. These traits are likely to result in difficult interactions with ED providers, whether it's physician or nursing. And so these manifestations may be interpreted by clinical staff as signs of mental illness and may cause friction and leading to sometimes even ejection from care. And so the four principles of trauma-informed practice are trauma awareness, emphasis on safety and trustworthiness, and opportunities for choice, collaboration, and connection, and finally strength-based skill building. One important thing to know, just going back to the previous slide here, is that oftentimes we seem to have a cognitive block in thinking that, in my conversations with colleagues around this concept of systemic racism. There seems to be this misconception that systemic racism is a phenomenon where everyone in the healthcare system, everybody you literally see, is an explicit racist. And that is not what systemic racism is. All systemic racism is when a system, while functioning as intended, produces different outcome for different races of people. That's all that systemic racism is. And the challenge with these aspects of trauma is that if these interactions produce difficult interactions and result in disruptions in the quality of care or even ejection from care, then again, this system is functioning as intended, being disrupted by the impact of trauma, and produces a less desirable outcome for a group of people. While you're not explicitly selecting a race of people to discriminate against, the outcome is very much the same. And so that's how we can actually contribute to systemic racism using markers that are not necessarily the race directly, but act as a proxy for the race. And so working effectively with patients affected by trauma requires providers to be aware of the potential impact of trauma. This can then lead to reframing of how we perceive and relate to the patients. And for example, instead of viewing the patient as being manipulative, we can understand that the patient may have difficulty asking directly for what they want. Instead of thinking about what's wrong with people, we can think about what has happened to people. We'll now examine the 3 areas of the clinical process that can be impaired and explore strategies to optimize each of these processes through the lens of implicit bias and trauma-informed practice. As emergency physicians, we rely on clinical suspicion to guide our clinical process from assessment to disposition. And so our entire clinical process could be flawed if we start with an inappropriately low clinical suspicion. An example of bias setting the stage prior to the physician assessment involves a CTAS scoring system in the ED. CTAS scores can affect anywhere from where the physical location of the patient could be allocated, the timeliness of assessment to physician, and the intensity of monitoring, all prior to the physician even picks up the chart. And First Nations patients are less likely to have an urgent CTAS score 1 through 3. And this may be partially attributable to poor family physician access, leading to seeking some degree of primary care that would otherwise be sought in the community in the emergency departments. However, the CTAS 4 to 5 admission rate is 50 to 70% higher amongst the CTAS 4 to 5 group in BC for First Nations patients. And so this is much higher than expected, and this raises the potential that these CTAS 4 to 5 patients are not, in fact, actually CTAS 4 and 5s. Some of them may actually be 3s or others. And so we should therefore be aware that there may be the phenomenon of under-triaging, and that we may need to escalate the intensity of the patient's monitoring or change the patient to a more appropriate care space if we suspect under-triaging is present. Another source of external bias could be the equipment that we use. Studies have demonstrated that pulse oximetry can overestimate oxygen saturation by around 2% in Black patients. And in some previous studies have demonstrated similar findings in darker skinned individuals. And so in the area of COVID, this could have significant implication on how patients are treated, including those who get treated with steroids versus those who are not, or those who are admitted versus those who are discharged. And so this may, in fact, have some impact on darker skinned Indigenous patients as well. And this all really goes to show, again, who we're centering the healthcare system around. And it's always important to keep in mind that when Indigenousness is not centered, when we center a certain, when we center around our worldview or our norms in a Western-centric way, that's, that is by definition a system not being designed for Indigenous peoples, or in this case, not even being designed with inclusivity towards Indigenous patients, and therefore by definitions, people's needs would be unmet. And so clinicians would need to ensure that patients are not discharged solely on the basis of pulse oximetry readings and may need to take into consideration other clinical factors or the overall clinical presentation, including potential for following up with arterial blood gases if there's a stronger suspicion than what the pulse ox is reading. Another source of external bias is the impact of stereotypes. The In Plain Sight report has documented widespread Indigenous-specific stereotypes across the BC healthcare system.
Playing from MacBook Pro 4.
Numerous examples here on the screen. Not only do these stereotypes contribute to poor experiences, they may also have an impact on provider decision-making. An example would be that previous research done around anti-Black implicit bias showed that when clinicians are primed with Black faces subliminally, physicians are more likely to react quicker to stereotypical diseases. And these are not limited to genetically predisposed diseases like sickle cell anemia or otherwise, but also conditions such as obesity or substance use. Other studies include things like clinicians are more likely to miss eating disorder in non-Caucasian patients. And so it shows us stereotypes have an impact, racial stereotypes have an impact on the clinical decisions that we make and could potentially lead to misdiagnoses. Stereotypes may also lead providers to seek stereotype confirmation from the patients. This may cause us to overvalue the patient's behavior and attitudes as factors contributing to their illness. And implicitly, this may cause us to internally demand the patient to prove themselves worthy of care. We may then miss more relevant factors contributing to the patient's illness and damage our therapeutic relationship in the process, leading to perpetuation of the patient's unmet healthcare needs. And unfortunately, these unmet needs may then further contribute to the patient's own stereotype. And so in order to mitigate the effect of stereotypes, providers may need to ensure that all the information being used to make clinical decisions are derived from accurate history of physical rather than from assumptions. When working with Indigenous patients, providers should also be aware of a higher rates of chronic conditions. First Nations patients have a higher prevalence of rates of 14 out of 16 chronic conditions listed here. And so we should consider how higher prevalence of chronic conditions may affect our pretest probability. Another factor that may lead to us needing to adjust our pretest probability higher in Indigenous patients traces back to the determinants of health. Adverse determinants of health has been shown to predict hospitalization and mortality just as accurately as conventional cardiac risk factors. And so with higher rates of adverse determinants amongst Indigenous patients, this should lead us to having higher clinical suspicion as well. Patients may have inadequate assessment because of inappropriately low clinical suspicion. And this, again, like we were talking about earlier, could confine us to inappropriate care spaces like the hallway with a low CTAS level, and that may impair our ability to take an accurate physical exam or taking an accurate history. But impaired communication can also lead to the clinician's ability to gather high quality information. So what we'll cover in this section may actually seem like common sense and may seem like part of everybody's existing everyday practice, especially in amongst ourselves who are earlier in our careers, who may be quite focused and quite critically reflective upon our everyday practice as part of our professional development at this stage. But it is possible that we're more likely to engage some of the tools that we're talking about here when we're working with patients who we inherently empathize more with. And because of the impact of implicit bias and trauma, like we talked about earlier, there is a possibility that this potentially can affect how we relate to our patients. And therefore, with less ability to relate to our patients, we may be inherently less likely to use some of these tools. I think clinicians were pretty good at using these patient-centered tools on, like we talked about, like on the patients that we like and we can identify with. The second category of people who are very good at using these are people who we explicitly have difficulty with. Like, for example, if you are in a small town and you have to treat your sworn enemy, I can be pretty sure that you'd be utilizing all of these tools, because any area that doesn't go well will be perceived as explicit bias on your part. And so we're very good at, mitigating that in people who we very much identify with and the people who we have clearly a lot of difficulty with. The challenge is that with implicit bias and with trauma, we may actually just be indifferent towards some people that are affected by bias and by trauma. And this category of people we may actually miss in terms of looking at some of our clinical approach. And so, as we've discussed before, poor healthcare experiences can directly or indirectly affect Indigenous peoples. Even people who have not personally encountered poor treatment may be concerned about poor treatment from family experiences or even just watching the news. And so we, as providers, it'd be helpful for us to recognize that individuals may feel unsafe due to prior experiences. Sometimes in the emergency department, because of our busy schedule and because of our time pressure, we may sort of brush aside or try to skip over expressions of anger or frustration by certain patients, because really focusing on those expressions may not help while they're there, and actually just really could take time away from other patients. But specifically with Indigenous patients where there's a long-standing history that we didn't talk about previous experimentations like nutritional deprivation experiments, or even more recent experiences like coerced surgical sterilization, which have been documented, the degree of unsafeness is fairly profound. And so lacking acknowledgement and empathetic response to people's negative experiences could actually provoke more mistrust. And so my suggestion would be to not expect or assume trust from the very beginning, but for each and every clinical encounter that we have with patients, we should make earning trust a distinct clinical objective to be achieved in every encounter. And this may include being responsive to the patient's immediate needs. It's pretty difficult for someone to be trusting of us that we'll be taking good care if they're sitting there and clearly shivering and uncomfortable, and we sort of ignore that and assume that nurses may look after that. And so that, that can damage rapport right off the very beginning. This seems like incredibly common sense. Convey a caring attitude. There's a number of quotes that from qualitative research to throw in here, and that we simply just don't have time to go over. But there is a very well-established basis in literature on patients experiencing a non-caring attitude everywhere throughout our healthcare system, but in particular in the emergency departments. That dates back for decades, not just the most recent In Plain Sight report. And so caring attitude is actually something that can be very important, because one common concern from Indigenous patients is feeling like they're impersonally being passed through a system where their needs may or may not be met, with no one being invested in looking after well-being. In each clinical encounter, consider making sure that the patient knows that you've actually seen them as a human being, and that you've connected with their humanity, with your own humanity. And in the ED, it can be fairly difficult to do when we're going through a fast-paced environment. But again, I think for this specific population, I think this is where some of the deficits are in terms of being able to actually gather enough trust to be able to get the rest of the information. And an example of this could be, taking this out of the Indigenous context. If someone came in with some scratches and injuries on the arm, and the patient may not feel a sense of care from the provider, they may just let you examine the arm, but they might not let you know that they've injured themselves during that same fall in the perineum, but they don't necessarily want to reveal that to you if they think that you're going to be very rough with them, or they may not convey to you the reason why these injuries were caused, and that can potentially lead to a lot of missed information. And so in ED, it's fairly common to for our focus to be to take steps proactively to move patients through their ED journey without necessarily explaining this to the patient in a timely manner. And particularly for marginalized patients, this can eventually lead to patients being disengaged as they begin to wonder whether their needs will be met. It's therefore especially important for us to convey the plan as well as the progress. And this may seem somewhat surprising, but I do often have specialists like surgeons, etc., asking why I think Indigenous patients may not, for example, attend their colonoscopy appointment or something like that. And I think the explanation is somewhat I think the explanation is fairly present in front of us all along, in that when Indigenous patients face barriers throughout the healthcare system, and not just throughout the healthcare system, but also in greater society as a whole, where needs are routinely unmet, why would they think that you, this person in front of them, is going to meet their needs at this particular time, if so often needs do go unmet? So there is an opportunity cost of presenting to us, and yet we're not necessarily a sure thing, despite our best intentions, and especially based on past experiences. And so conveying, again, going back to this, conveying a caring attitude and ensuring that people feel seen is important to hopefully to earn, go toward earning that trust, and can potentially improve our communication. In the ED, it's pretty common for us to focus on gathering information quickly and efficiently. And so this may mean less emphasis on considering the impression that our questions may have, may be leaving with our patients. And for Indigenous patients who are consistently facing misconceptions and stigmatization around alcohol use, this could be especially damaging. So consider prefacing certain sensitive questions with an explanation. Here in this example here, they talk about, asking about, that we ask these questions for everyone. I put this up there mainly as an example, but I often don't actually explain it this way, because the truth is I don't necessarily ask every single patient about alcohol use, but I do explain that this, out of this list of considerations of, for example, weakness or falls or altered mental status, or, depending on whatever the presenting complaint is, here are some of the common things that we consider, and alcohol being one of them, and therefore it's important for us to find out. And just because I think if we go around telling people that we ask everybody, they do listen through the curtains to what other people are asked, and if it's patently untrue, I think it goes further to damaging truthfulness. Commitment to communication, I think, is also important. So being aware that silence may not mean agreement, consent, or lack of concern. The quote here says that that says a lot when you're silent as First Nations, because you're thinking about what's being said and you need to give the right answer back. So considering pausing and making space for the patient to respond, or following up with more open-ended questions. It's been commonly shown in qualitative research that rapid focus on diagnosis and management is perceived quite poorly by patients, and really impairs the trust in the subsequent management plan that's provided, even if it's appropriate. Being transparent, consistent, and predictable. So as a continuation of building trust, patient likely appreciate transparency and consistency. Consider the patient's perception and recognize that unaddressed negative perception may be just as damaging, regardless of whether there's bad intent or whether or not it actually caused any actual bad outcome. So again, prefacing sensitive questions with an explanation, ensuring that promises are kept and that patients are not made to feel guilty for provider errors. Again, oftentimes in the ED, with our time constraints, we may not always be transparent with our processes, and we may not always apologize for delays or for miscommunication, even if we're at fault, or we have contributed to that in some way. And in marginalized populations, this does contribute to the sense that they're getting the runaround. And so we really do need to, as providers, actively avoid giving people the sense that they're getting the runaround. Colonialism and trauma makes power differential an especially important consideration in Indigenous health. And this is fairly pervasive throughout all care settings in terms of difficulty with interactions with persons of authority because of negative interactions. Examples outside healthcare include things like Indigenous peoples are actually 10 times more likely to be shot dead by the police than non-Indigenous peoples, and Indigenous peoples losing over 70 times more life to incarceration than cardiac disease in Canada. And so it's those are not small numbers, and goes to show that how the rest of society can also accentuate the power differential between us and our patients. And patients may avoid healthcare providers or lose trust when they feel that the physician is too prescriptive or authoritarian. And this impression can come from a tone of voice or communication style, and again, may lead to disengagement. Now, this should cause each and every person to stir, budgeting more time. Because of the complex personal context, Indigenous patients may benefit from more time in being able to initiate and sustain meaningful clinical dialogue. There's also the phenomenon of stereotype threat, where patients may need to exert mental energy in order to actively avoid confirming common stereotypes. And this may lead to the patient looking cold or looking disengaged or looking rude. But in reality, it's the amount of mental energy that goes towards trying to avoid confirming stereotypes on behalf of themselves or even other people. So budgeting additional time from the very beginning can decrease the stress on both the provider and the patient. Obviously, in the emergency department, time is our most valuable commodity. But we intuitively know that patient context can make two similar presentations take very different amounts of time to assess and treat. For example, a 30-year-old patient with vaginal bleeding in the first trimester would likely take more time than a non-pregnant patient with the same presentation, even if ultimately the degree of medical complexity is not necessarily dramatically different or immediately life-threatening. We also intuitively know that certain populations take more time to assess, like geriatric patients or sexual assault survivors. And so we would likely need to consider Indigenous identity to be one of the patient populations that require additional time. It's sometimes at the end, it is possible to just run out of time and you cannot meet all the needs. And that is not necessarily a failure, but sometimes I would actually just be transparent in my communication with the patients, and just go forth and say, it sounds like we were not able to meet all of the needs that you came in today. And I'm sorry for that, but that is the limit of what we can pursue today. I do really want to encourage you to come back, or I'm going to refer you to this this service, or I would like you to come back so that perhaps during the daytime when we have more resources, so we can focus on some of the other situations, and just even being transparent with that, I think can again provide a patient the impression that we are actually attentive to patients' needs. And finally, providers should be aware that there is evidence of disparity in the rates of investigations among racial minorities. And so carefully considering decisions not to investigate to ensure that it's not informed by assumptions or stereotypes, and to ensure that adequate rapport was built, so that patients are less likely to have information that they have not yet shared or abnormalities that they have not yet brought to our attention. Part of meeting people's needs is addressing pain. Research show that persons of color are less likely to receive opioids or less likely to receive a prescription for analgesics, not limited to Indigenous patients, but just racial minorities in general. And there is certainly evidence out there already to suggest that some providers are hesitant to prescribe pain medications to Indigenous patients out of stereotypes around addiction. And so this not only increases suffering, but also damages therapeutic relationship, but also increases the risk of self-medication. So consider the use of standardized pain management and prescription tools and opioid agreements, etc. And for those who have more complex conditions, consider using a consultant service such as pain specialty or addictions medicine support. The opportunity to collaborate and for choice can be especially important to achieving buy-in. Invest time in finding out the patient's preferences and work together to address barriers in care. Inviting the patients to share their priorities are also equally important. It's extremely important, though, to demonstrate to the patient that you've taken care to optimize their results. Again, demonstrating investment and demonstrating care, and again, in order to build trust. One thing that I'd like to say here is that sometimes with patients declining medical treatments, sometimes we sort of default back to this, that, you know, does the patient have capacity? And if the patient has capacity, then and they decline the treatment, then we just let them go. I would suggest that we add a second consideration to that in addition to capacity. I would suggest that you must be convinced that you have earned the patient's trust. If you have not earned the patient's trust and they decline a procedure and they decline the treatment, then I don't necessarily know that that constitutes informed decline. And so we may need to put a bit more, obviously I'm not suggesting you force treatment on anyone, but you may need to reassess whether or not you've adequately built trust, and if anything there can be optimized. This is an area that we do likely not enough in emergency medicine, affirming strength and resilience. So providing genuine, specific, and relevant affirmations to build self-sufficiency and to acknowledge strength of patients that may be going through a lot in other aspects of life. Supporting cultural needs, inviting and supporting cultural practices of care. And in the ED, this oftentimes more likely takes the form of non-interference rather than active facilitation because of the limitations of the ED, although there may be specific exceptions such as patients who are palliative and actively dying. And so consider that some patients may have larger circles of care that include elders or extended family members. And so this can enhance collateral information, increase adherence, and improve continuity of care as well. Also consider the real or perceived impact of barriers in care, including attitudes, policies, fees, and the physical environment. All can contribute to the opportunity costs and the perceived accessibility of the emergency department. Even simple things like fees for notes and things like that can have a significant impact on patients. And as we talked about the gaps and determinants of health, so making sure that we use adequate resources to support determinants of health. There's the poverty tool, for example, you can print out the back pages on different things like free legal advocacy or how to find the food bank or things like that. Especially in places where social work may not be accessible or during hours when social work is not available, this can be very helpful for patients. First Nations patients are generally covered under FNHA health benefits, and this includes vision, dental, medication, medical travel, medical devices, and mental health, and could be important to take advantage of, especially with those who may otherwise have limited means. Patients registered under FNHA benefits are also covered under Pharmacare Plan W, and so sometimes certain medications may not be covered or be partially covered. And so if patients say that that medication hasn't been covered before, you can consider making an alternate prescription by searching up some alternatives and making sure that they're covered on the formulary. Patients are covered for their for over-the-counter medications with a prescription from you, and the list of over-the-counter medication covered can be found there. For patients with mental health concerns, consider connecting the patients with culturally safe mental health supports, including Hope for Wellness helpline, which is 24/7, and actually will connect the patient with actual counseling rather than just crisis intervention. There are also psychiatric and addictions consultations, specifically for First Nations patients with providers who are specifically interested in cultural safety, and so that can be a good resource. And there's also dedicated resources for residential school survivors. As we know, Indigenous patients who have a higher rate of leaving against medical advice or left without being seen. And so consider exploring and mitigating barriers in order to identify unmet needs and prioritize de-escalation and meeting the patient's needs over the involvement of security and the police. And again, like we talked about earlier, we should recognize that there is a lower attachment rate to family physicians. And so in the ED, we can refer the patient for attachment in departments where that's readily available. And for patients without family physicians, consider making an alternate follow-up plan, like another clinic that you may have access to, like even including internal medicine, for example, if that's the appropriate thing in the local context, rather than simply deferring follow-up to non-existent family physicians. As a backstop, this may not be necessarily the ideal use of the service, but the First Nations Doctor of the Day service does offer primary care via virtually as a stopgap for patients who are awaiting attachments. And to summarize, the CAMH Bill of Rights essentially summarizes many of the key points to providing effective care for Indigenous patients. And here's some additional resources. Here's a video on working with Indigenous patients from the perspective of Indigenous healthcare providers. And these will be sent out to you. The In Plain Sight report, I would encourage everyone to review, especially just the key points. The topic of trauma-informed practice is further elaborated on in this useful guide with some specific tools. The Royal College has a specific Indigenous Health primer that looks at a variety of useful topics. The EQUIP study has a number of equity-oriented practice resources, including the Equity Talks pocket cards that we talked about earlier, as well as some research publications, including the upcoming study on emergency department equity. There are a variety of cultural safety resources that are available online as well. And so thanks for your attention. The existence of population health disparity has its origins in the adverse determinants of health faced by Indigenous Canadians, and the very purpose of the healthcare system is to offer a way to alleviate these disparities from causing people to fall behind in other aspects of life. Currently, how healthcare is being delivered predisposes us to healthcare disparity and really perpetuates some of these disparities and potentially even exacerbates them. And so with each interaction with an Indigenous patient, there's an opportunity to address and alleviate these disparities. And this is our opportunity to contribute to reconciliation in a concrete way. Thanks very much for your time.